So welcome everyone to Generation Study. So today we're going to be talking about Generation Study in Genomics England and how they work with the NHS in partnership. What exactly is the Generation Study, what our aims are, where the study is running, what we're doing for study equity, and then Sally will go on to talk about our return of results. So essentially, Generation Study is run by Genomics England. They're a government-owned company focused on genomic research. Some of you may have heard of the 100,000 Genomes Project, which studied the role our genes play in health and disease. And that included NHS patients affected by a rare disease or cancer. And they work in partnership with the NHS to integrate genomic testing into routine healthcare. So the role of the NHS is to collect patient samples and clinical data, which Genomics England can sequence and analyze. The results are then disseminated to NHS clinicians to support diagnosis, treatment, and personalized care. And together we can build a secure genomic data resource, which supports our ongoing research and improvement in healthcare within the UK. So we have a short video to introduce the study. I'm hoping this is going to work. If not, no worries.
Have we frozen? Have we frozen?
Can people not hear that?
No, not at the moment.
Okay, no worries. We'll continue on. So essentially, the Generation Study is a long-term research study, and we're aiming to understand if we can improve how we diagnose and treat genetic conditions by looking at the DNA of newborns. We know that early intervention of these conditions leads to better outcomes. So it involves collecting a blood sample, either from cord blood or heel prick or indwelling line. And with that, we can read the baby's genome. And we're hoping to screen for over 200 genetic conditions that will all require treatment within the first few years of life. So the main study aims are to, of course, identify these conditions in babies. And we want to know whether it's feasible to perform genome sequencing on a large scale, what the ongoing impact is of screening newborns this way on the NHS downstream. And all of these conditions we screen for are childhood onset, and it includes things like growth and hormonal, blood disorders, immune disorders, and metabolic conditions. It doesn't replace the day 5 newborn blood spot test. There is a crossover of some of the conditions such as cystic fibrosis, haemophilia, sickle cell disease. But in the meantime, while we're still seeing how accurate this test is, how many false positives we might get, we still want babies to have both of these tests just in case. The second study aim is to, of course, enable further research. So we can use the data we collect from the study to keep learning about how our genes and our health interplay. And with that, we can improve our testing and diagnostics of genetic conditions in the future. And all of that is stored on what's called the National Genomics Research Library. And this essentially is creating a lifetime resource. And with that, we can explore what the long-term implications of storing a baby's genome over their lifetime, how we might use that in the future to decide which treatment pathways are best or rescreen for other conditions. So the study opened in 2024. It opened in Bristol first. We have a national target of over 100,000 babies, so it is a large study. So far, we have about 18,000 recruits. All of the conditions we're looking for, they are rare, but they are treatable on the NHS. So there are around 9 babies born each year within the UK with one of these conditions. So we're actually only expecting about a 1% rate of these babies to have a condition suspected result, which works out as about 1,000 results. So how the study actually works, while birthing people are still pregnant, they're approached during their pregnancy by research midwives or genomic nurse practitioners, and they're counseled on what exactly it means to have their baby's genome sequenced and stored, how it might impact them in the future. We help them make an informed decision about whether having their baby's genome sequenced is actually right for them. And not everybody will want to do this. Not everybody agrees with genetic testing or worries about the implications of having a false positive, things like that, which is what we talk about in detail. And it's also really important for us to understand the reasons why people might decline having genetic testing. If we want to know if this is something we can roll out on the NHS eventually, is it something that people will be open to? So ideally, a cord blood sample is collected at birth. We want it to be a non-invasive test. Um, so currently, the study is only open to single pregnancies because of the cord blood. They don't want it to be multiple pregnancies at the moment. And following the sample collection, they receive either a condition suspected or no condition suspected result. And an important factor for families to understand is that this is primarily a screening tool, not a diagnostic tool. So those with conditions suspected will be handled by return of results team, which Sally will explain shortly. And then following that, the data is stored with Genomics England and with the National Genomics Research Library to continue on our research. And then they might also get ongoing contact about what's happening with the study, what we found. They might also be invited to take part in other studies. So currently, with the studies only running in England, we have 27 trusts and about 45 hospitals running the study. We have many, many more sites that are undergoing the onboarding process. We have a goal of roughly 30% of our birth cohort per hospital to recruit. Each hospital has a different way of recruiting, and we have different dynamics in our teams. But one of the most important things we found is face-to-face recruits for people who need a bit of extra support, understanding genomic testing, and also having that connection with and continuity with a midwife that they can recognize that actually works at their hospital is really important for them to see that this is something that we're hoping to be integrated into normal NHS care and to try and break down those barriers of that research is scary and genetics is quite confusing for some people. So in terms of study equity, we know that those with non-European ancestry are largely underrepresented in genomic research. So what Genomics England want to do to address this and support actual outcomes in genomic medicine, they have their translated materials in 17 different languages. That includes participant information sheets, consent forms, subtitled videos, and they are working on doing videos with as well. So they work with communities and attend events and networking opportunities, such as Women's Health Event, Black Health Inequality Summit. And they engage with these local communities to hopefully gain feedback about the study and how our recruitment process works and what the barriers might be. And this is a really essential part to support participant engagement in underrepresented communities. So I'm going to hand over to Sally now for return of results.
Hi everyone, so I'm Sally. I'm one of the return of results coordinators for our Southwest region, and I share the job with another colleague who's not here today. So I'm really here just to talk about the second part of that diagram, as you can see there, where we are receiving a result and the patient's receiving care. If you could, next slide please, Vicky. So as Vicky's talked a little bit about the types of conditions that we look for, whilst we're doing whole genome sequencing, we aren't giving data back to patients for their whole genome. We are looking at a defined list of conditions, of which there are about 200, but more may be added and some may be removed during the process. So it is a bit of an ever-changing list. And the babies will just be tested for the current list when the sample is received. And it's likely that that list will probably be refined in terms of longer term planning and the 10-year plan for NHS to possibly introduce this as a standard test. So at the moment, it's very much research looking at those conditions. Next slide, please. So it is a screening tool, and as I said, whilst it is WGS, we will limit what number of genes are looked for, but also the specific variants that we're looking for in that gene. So we are only looking for variants that are considered pathogenic or likely pathogenic, and anything of uncertain significance won't be reported. The result is also a research result, so it's not a diagnosis, and it's important that when we're communicating those results that's clear, that further tests may be needed and the baby may be well, and that in reality it only looks for these known conditions and the known variants. So there could still be concerns about a baby. It's not going to rule out all possible genetic conditions. So if there are any concerns about baby's development or health, then routine NHS care and investigations should still be undertaken. Next slide, please, Vicky. So when we get a condition suspected result, what we know is that we found a variant or one or more variants, depending on the inheritance, in one of the conditions that we test for, and we know that it's a suspected condition. What we don't know is if baby definitely has that genetic condition, and especially in what we call recessive genetic conditions, further genetic analysis is needed to confirm that the variants detected are what we call in cis and not and so are coming from each parent rather than being on the same gene or chromosome. So further analysis is needed. There are, in all of the tests, there are paperwork that comes with all the conditions about further diagnostic tests that the clinicians will need to undertake to try and help find clarity about whether this is a confirmed diagnosis. And so further testing is needed in an NHS accredited lab, as well as other diagnostic non-genetic testing. We do know that some of these conditions will have what we call variable penetrance. So that could mean that the baby's well and may or may not go on to develop symptoms of the condition. And that's part of the research that's being looked at. And we should certainly know we wouldn't normally test well infants for many of these conditions. So we may find some babies with that reduced penetrance who are essentially well, but have the genetics that could put them at higher risk. And we know in genetics that that is a common phenomenon. So it's refining that list and making sure that we're giving results that will be helpful in the longer term. New slide, please, Vicky. So in terms of communicating results, I'm involved in the left-hand side, so that's where there's a condition suspected. The estimate was that we'd probably pick up around 1% of babies with a condition suspected, but currently that's much lower. It's about 0.4% of babies. There was public consultation before the study went live, asking prospective parents about what they would want in terms of getting results, and the general consensus was that they would want results being given from a clinician with specialist knowledge in that specific condition. So what happens is that if we have a condition suspected result, then we liaise as results coordinators with that specific clinician, depending on the condition within our region, and help them to support them to deliver the results to that family by phone. It's usually within a few weeks to months after the baby's born. We are getting the results back quicker and quicker now. And their job then, the care of that baby then moves into routine NHS care, and it's up to the clinicians to arrange an appropriate appointment with that family to discuss the results and then appropriate ongoing testing that's needed to confirm the diagnosis. I think the assumption maybe was that many of these babies may be sick already and having investigations, but certainly with a lot of the results that we've had for our region, that hasn't necessarily been the case. Sometimes it's adding quite a bit of burden onto those clinicians to deliver results to patients who are effectively well at the time. But ultimately, it is expected that they are conditions that at some point the patient's care will likely come into a diagnostic setting. So it's just bringing those appointments earlier and getting clinicians and patients used to that different way of working. Where there's no condition suspected result, we don't get involved, or where there's a failure of the sample for some reason, again, we don't get involved as return of results coordinators. Those results come back directly through GEL in a letter form for the family. Next slide, please. So return of results coordinator, myself and my colleague Nikki are the first point of contact. Our role is to work out what the right clinician would be, to contact them as urgently as possible and to send over the referral pack with all the information. We can provide follow-up support to ensure smooth delivery and return of results. We liaise with the national screening lab, so if there are conditions that are already picked up on newborn screening or can be picked up on newborn screening incidentally, we liaise with our local NBS labs to find out if the patient's already known and who's managing their care. We can provide support around pathway for delivery. We will follow up with clinicians to make sure that they've completed study documentation. Both myself and Nikki, who are return of results coordinators for the Southwest, so that's from Gloucester down to Truro, are genetic counsellors. So we can also provide genetic counselling knowledge and also support ongoing genetic counselling support for those families. Not all the return of results coordinators for the country are genetic counsellors, so they may have slightly different context and understanding about providing that genetic counselling knowledge at point of return of results, but there is dedicated genetic counselling time allocated across the country in slightly different ways for families for ongoing follow-up and support. Next slide, please. So we send out a rather lengthy email once we've spoken to the clinicians, which has some of the information, as you can see here. Primarily, it has the study report, which looks a bit like the one on the right that you can see, along with the information about the family, the guidance for confirmatory testing, links to complete the study paperwork, and sort of guidance for calls and emails if clinicians feel they need that. Next slide, please. So just to summarise really, for the family, when there's a condition suspected result, they should get a phone call from an NHS specialist. Further follow-up testing is needed in order to make that diagnosis, and once the diagnosis has been confirmed, then ongoing care and treatment will be arranged by that local specialist clinician, which may include referral to genetics for genetic counselling. And then there is feedback into the GEL about the study. There's something called a DOTS, which is an outcome, and a C guide, which is about clinicians' experience, and other data is collected. And once that's returned, then the family may also get ongoing contact about the study. So in terms of results so far nationally, there have been 48 condition suspected results. As I said, that's about 0.4% of the patients. 15 of those are conditions that are on newborn screening or being evaluated for newborn screening, such as SCID or severe combined immunodeficiency. And the rest of the results on the next slide, please, Vicky. You probably don't need to take all of that in, but the take-home message there is that there are a huge different variety of conditions across multiple specialties. Some of those specialties are used to dealing with newborn screening results, like the metabolic team or the haematology team, whereas some of those conditions are to specialties who are not used to delivering this type of result. So our neurology, nephrology, endocrine team have had to pick things up, which they are also learning and working out best ways to communicate information. And that's from early September, so there may have been a couple more cases since then. And I think that takes us to the end of the presentation. So thank you for listening. If you've got any questions, I think there's time for questions in a minute. Those are the general email contacts. If you did have any questions about recruitment, you can contact Vicky on the bottom email, and if you are wanting to find out any information about return of results for any patients or have any queries, you can contact myself or Nikki on the RRC email at the top. Thank you very much. Hopefully we haven't overrun for you guys.
Okay.